We are going to get to our presentation. It is the importance of the healthcare system during disaster. We are thrilled that Danica Little from the UW Medicine System can join us. She is their preparedness manager. Cindy and I were thrilled to hear this talk at the Disaster Management Committee meeting that we go to once a month at the Office of Emergency Management. So we asked Danica if she would come and present similar information to the hubs so that we kind of understand what her hospital system and actually the big hospital systems here in Seattle, what they're facing post-disaster. So I'm going to stop sharing and turn it over to Danica.
All right. Thank you all for having me here this evening. I'm Danica Little. I'm the Director of Preparedness and Business Continuity for UW Medicine, and I co-presented on a similar topic with my counterpart at Swedish Medical Center in August, I think it was, at the Disaster Management Committee for the City of Seattle. So happy to share with you today about what we do planning for disasters for the healthcare system, what we need from our community partners during a disaster, and what would be helpful things we've experienced in the past. And I'm very happy to answer any questions. I've been doing this for about 20 years. I started out with the King County Healthcare Coalition. Well, I started out in Snohomish County, and then I moved to the King County Healthcare Coalition when it was developing in the early days as part of Public Health Seattle King County, and then moved over to the UW Medicine System almost 14 years ago. So I've been primarily at the UW-MD Montlake campus, the one there on the university campus, and was promoted into this system role at the start of COVID and ran our preparedness response to COVID for UW Medicine. So happy to be here tonight and happy to answer any questions that you have. Okay. So I wanted to start with, I've been around a while. Many of you might remember I think it was the Hanukkah Eve storm years ago, where it took out power to most of King County, except for the city of Seattle. And during that time, I was with the Healthcare Coalition, which was supporting all healthcare organizations in the county, including hospitals and nursing homes and clinics. And what we learned from that event is that hospitals tend to be this heated, lighted beacon on the hill. Everybody went there, and they didn't go there because they needed healthcare. They went there because they needed a hot meal. They needed to get warm. Their house didn't have heat. They wanted to charge their cell phone or their iPad or gaming device for their kids. And it became really problematic for the healthcare to understand who was actually there to be seen for a healthcare need or medical need and who was just sheltering in the hospital. So I want to start with that, is that we acknowledge that we have requirements to have generators and have food and have water. And our plans really account for that for our patients and our staff, but not for the community overall. And this is where I'll just start with an ask up front. And you all, as I understand it, help to organize the hubs in each of your communities. And I think that would be, at the end of this, we can revisit it, but it will be an important piece for community members to understand. If they have a medical need, we will absolutely do our best to be there for you. If it's just that you have to charge your cell phone or need a hot meal, there are other resources in the community that can help with things like that, and we will help connect you to those if they're not immediately known where they are. But we are seen as this place for shelter, for food, for heat, and on your worst days, we are who you visit. And when you need medical needs, we are the people you come to see, and it's natural for people to go there. Each hospital in the city of Seattle is unique and has different services that they provide. So some hospitals don't care for children. Every emergency department does, but not all hospitals have beds for kids. And I think it's important, if you have parents in your community, for them to understand the best places to take kids. For example, some hospitals are better at cancer treatment. Harborview is the trauma center for a 5-state area. So for trauma, you want to go to Harborview. So there are different things that we each prepare for, but I will kind of do an overarching of how we do our disaster planning in the healthcare systems. So we do plan to be self-sufficient for up to 96 hours. And what that means is we try to stand alone without resupply. without resupply of medical supplies, food, water, fuel for our generators, medications, and we plan ahead. We know what our day-to-day patient load typically is, what supplies we use on a normal daily basis, and we plan ahead. We call them PAR levels. We keep those PAR levels at 96 days, or I'm sorry, 96 hours. 96 days would be enormous. 96 hours to be able to support ourselves without the expectation that vendors could get in to supply us and such. So the things that we plan for infrastructure is a big one. If we cannot turn on the lights and open the doors, it's going to be really hard for us to help our community. We plan for staffing and supplies. Without things and people, we also have a hard time seeing people. And then we plan for food and water, which I mentioned, and then education. If people don't know what our plan is, it makes it really hard to keep everybody going in the same direction. So we do a lot of it, staff education. For those of you who are not familiar with UW Medicine, we have 4 hospitals, and in the Seattle area, we have 3 hospitals. And in those 3 hospitals, we house over 1,200 patients on any given day. And I have kind of the breakdown here for you. Harborview has close to 500 beds. They are the level 1 trauma center for a 5-state area. They also house what's called the King County Disaster Medical Control Center. And what that means is if there's a mass casualty incident or a big incident of a lot of injuries, Harborview provides the direction to the medical services officers for EMS that are at the scene as to which hospitals to take those patients to. And they coordinate with the hospitals over the radio or over the phone and ask, how many of this type of patient can you take? And they're triaged by colors. Red, yellow, green. Reds are most critical. Yellows could go either direction, become a critical patient or get better on their own. And green are usually like a walking wounded. They don't necessarily need EMS transportation, but they do need medical care. So Harborview provides that service to all the hospitals in King County. If there's a multi-county event or something that is impacting the entire state of Washington, Harborview also houses the Washington Medical Coordination Center for that service as well. And that they work every day, both of those programs. The Washington Medical Coordination Center came out of COVID. So we daily are placing patients and looking for beds based on patient need. Like I think this week it was, there was a spike in, we were looking for beds that had dialysis for patients, and they coordinate with hospitals on the east side and the west side of the state through the Washington Medical Coordination Center. Harborview is also the only burn center in Washington state. They have a pediatric ICU. They do neurology, and ECMO is a device that helps your blood pump through your body while you are in the ICU. And there are very few hospitals that do ECMO in Washington state as well. Our Motley campus at the University of Washington is what we call a quaternary specialty care facility. They do a lot of, we see the sickest of the sick at this hospital. We do a lot of oncology patients, transplants. That is a ventricular assistive device or a fake heart. Only a few hospitals in the state provide that type of service as well. Also, we do ECMO, and they have one of the top level NICUs or neonatal ICUs in the state. Northwest Hospital up by Northgate has an average of 185 beds. We also just built a behavioral health hospital on that campus that has an additional 150 beds. So it's becoming a big campus. It's more of a community-based hospital. They do a lot of orthopedic surgeries, geriatric psychiatry, and mother-baby unit are some of the bigger labor and delivery, some of the bigger programs. And then we also have Valley Medical Center in Renton that also serves as a backup trauma center and a community-based hospital as well. So just to give you an idea of the scope of services that we offer at UW Medicine. So to get into the critical infrastructure needs, and this is what we were talking about at the Seattle Office of Emergency Management meeting, what we did, I partnered with Chris Ledoux, who's my counterpart at Swedish, to come down, and we thought, between the two of us, we have most of the hospitals in Seattle, and we wanted to speak to our city partners about what we need in a disaster for critical infrastructure to keep going. So we kind of just talked about these 6 categories. Water is essential, and why it's essential, it's not just for hand washing and hygiene. Everyone on here is for sterile. Sorry, Ellen, did you have a question? No, okay. It's for sterilization, as well as the chillers. Chillers help keep the temperature control in the hospital. And that is really important for our ORs as well, and for our server rooms for our computers. Power, I think, is an obvious one. We all have generators. We all have, at least 96 hours worth of fuel for those generators. But know that generators don't power everything that everyday power provides energy to. So when you go into a hospital, if you're in a room that has a red outlet, the red outlets are the ones that work when we're on generator, and they are reserved for critical equipment and computers and lighting and elevators and such. Security access. Hoods are where they prepare pharmaceuticals and can fume. They're taking the gases out of the environment so that it's not going into the environment of the pharmacy. Phones are essential as well. We have many alternate communication methods. I will say that right up front, but phones really are critical. So when our primary way of communicating goes down, using our regular telephones, it really significantly impacts our way to call code teams, to call on-call physicians, to coordinate care across internally or across with community partners, like the transfer center or EMS providers, and externally with other partners like public health. Steam, we all in the greater Seattle area have a different way of generating steam for our facilities. And it is essential for heat. When steam goes down, it is very impactful on a hospital. Nobody wants to be in a hospital that's 50 degrees. That's just too cold. And especially when you're feeling sick and you're not well, that is just not a great environment to be around. So it is a very critical resource for us. It also is for central sterile processing so that we can keep our instruments clean, and for dishwashing as well. But the primary one for us is for heat. Chillers, like I mentioned before with the water, the chillers are there for temperature control, humidity control in the ORs, as well as maintaining our server rooms and lab processing. And then the last one for critical infrastructure really is medical gases. We do have ways to resupply and provide these in an alternate method, if not through the wall, but they are essential for surgeries, for procedural units such as endoscopies, for inpatient support for things like oxygen and other gases that they need, for patient treatments, and then for support in the emergency department. So what I wanted to talk about with this group, keeping those critical infrastructure needs in mind, is we organize our planning based on what we call an hazard vulnerability analysis. And this is a process that we go through annually to review what hazards could occur in our community and how they would impact the hospital. What is the probability of that happening, and what is the impact? And then we get a ranking of that tells us which ones are our top hazards. These are our top hazards for UW Medicine. For all of healthcare right now, IT failure is the top hazard. Cyber security and ransomware, healthcare is the #1 target, along with banks right now for ransomware. I'm sure you've seen it in the news for many other places. It is hugely impactful for us to transition from electronic medical records to paper records, and it does create a patient safety opportunity, which is why these hackers are very successful. So we have put a lot of planning and time into securing our systems, as well as educating our providers on how to work on paper and go to downtime procedures and go back to the days of paper and paper charts, so that we can still be successful, protect our patients, and continue to provide safe healthcare. Surge capacity could be used in a lot of different ways. We could experience a surge on our system. And what that means is we operate anywhere between 85 and 100% full every day at every one of our sites. If we were to receive an influx of patients that would make us surge beyond those numbers, we have plans for creating space in unique spaces, doubling up rooms, using hallways, using procedural areas and canceling procedures so we can put patients in those care areas. The plans differ based on the facility and what areas they have available, where they have gases available, where they have red outlets available. But we do have plans for surge capacity, and it also depends on staffing of how many patients we can safely care for. But we have plans for surge capacity for an infectious disease outbreak like we did with COVID, for a mass casualty incident. If something were to happen at one of our major stadiums, we have plans for receiving patients and expanding our ability to care for them, or any other event that I'm sure people could come up with in their mind. Earthquakes would be another one. Infectious disease outbreak, we've all just experienced this for the last 3 years. So that is top on our list. It is incredibly impactful. I am very proud to say UW Medicine was successful in this response. We never ran out of supplies to protect our healthcare workers, which I'm very proud to say. And we were one of the leaders in the nation in publishing our protocols so that other hospitals across the nation could follow, which was fantastic because we were the first area. Everett was the first area to receive a COVID patient, and UW Medicine was the second. So our providers and our teams were absolutely phenomenal in that response. And we have a pretty strong plan now based on that experience that we would follow again should something new come up. Earthquakes. We do live in earthquake country, as I'm sure you're all very well aware. The injuries historically that result from an earthquake are typically not your traumas. So we look at this and we have different disaster supplies on hand for earthquakes. Earthquakes tend to render our critical infrastructure systems more impacted than increase in patient demand. So we would be looking at water supply, power and fuel, resupply after 96 hours of medical supplies, meaning could our vendors cross the bridges and get up the roads to us to deliver supplies? That would be a huge concern. So one of the reasons that we do partner very closely with the city, with the county, with the state, is to help them understand our needs so that they can get those roads open faster for vendors for healthcare so that we can continue to provide care in our communities. They can get vendors to us with the things that we need. Inclement weather, as we all know, any amount of ice can really impact our city. I'll say snow, but really it's the ice that really hurts us the most. And that is hard on us to, one, transport patients. A lot of our patients, for the care that we provide, they do come from the 5-state area. We call it the WWAMI region, the Washington, Alaska, Wyoming, Montana, and Idaho. Those patients sometimes wait a couple of months for their appointments or their procedure because of the specialty care that we provide. And we want to honor those appointments. So transportation during inclement weather is really important because I'll tell you what, those patients will make it in for those appointments. And it's incredible. And our teams do the same. And they know that that's an expectation. If we can't safely get a staff member in, we will hold someone over and ask them to stay the day and work the next night shift or stay the night and work the next day shift if they can. So that's one of the plans that we have, sleeping arrangements for our staff, and we house them on site for critical areas that are short-staffed during inclement weather, and we feed them as well, or we try to arrange for transportation, meaning if they can drive themselves in, we will arrange for parking for them so that it's not a cost impact to our staff. And then critical infrastructure failure. Any of those that I talked about on the previous slide could really impact our facility in terms of our ability to continue to provide care. If we don't have the right medical gases, we cannot continue to provide the same level of care. If we don't have heat, we do not want mothers delivering babies in rooms that are 50 degrees. There are some specific considerations that we would need to move patients into a different tower and kind of focus all of our resources on one area or move them to a different site if one of our sites was significantly impacted. So critical infrastructure failure, I've put them all into one bucket here, but the bigger ones for us tend to be an HVAC failure. A phone failure wouldn't cause us to evacuate, but it is really impactful to us. Water outage, we've had a few water outages of different pipes. I know a few years back there was one on Pacific Avenue that broke and one of our towers at the Montlake campus had no water and we had to bring in hand washing stations. And that was about 20 hours, I think. So we were able to get by, but if it was longer than that, we'd have to cohort patients into other towers and take steps to continue to keep them safe, hygienically speaking, as well. So critical infrastructure also is a big area for healthcare overall. And when I say UW Medicine, all of our hospitals are thinking of this way. Thankfully, here on the West Coast, we have a different culture than a lot of other areas of the United States, and all of the emergency managers in the hospitals out here, we know each other really well, and we all share plans and work together on these. So it was easy to co-present with Swedish at the Seattle meeting because I talked to Chris all the time. City infrastructure that's critical to hospitals. This is what we shared with the city, just to let them know, hey, these are resources that are really essential to us, and we will be asking you, the city, to help get these back online sooner than later. Prioritize these resources for healthcare. We need access. Our staff and our patients need to be able to get to care when they need it. We need to be able to have our vendors resupply us at some point with medical supplies, pharmaceuticals, fuel, any number of things. We need communication and we need power. We can go without power for a certain amount of time, longer than 96 hours at most sites. But without phone lines, we rely on radios, and radios we do not have in every single department. We do have cell phones if cell towers are down. We also would then revert back to regular phones. We do have analog phones as well. So we, like I mentioned before, we have some robust contingency plans for communication, but they are not as plentiful as regular phones and cell phones. We work really closely with Seattle City Light. We have a lot of different power feeds that come into different facilities. And we've worked with them before when there's been planned outages or unplanned outages to reroute power to our main areas. City departments that we work with regularly, clearly we work with EMS all the time, as well as private ambulance companies. We work the police department all the time as well, and the fire department. Human services, we do a lot of community outreach, and we have a lot of community-based clinics. So we do work with human services frequently. And then transportation, we would really be relying on the buses to start up again, the link or the light rail to start up again. A lot of our staff commute via those methods and don't have a vehicle or another way to get to work. So those would be really important, especially for the hospitals on the Hill. A lot of our staff up there, they don't have a vehicle. They commute using public transportation. So getting our staff to work would be really important to have those resources. And then we work with the Office of Emergency Management. I'm sure many of you are already aware of kind of the authorities that come with emergency management, the legal process that needs to be followed when requesting resources and creating situational awareness and reporting that needs to be done throughout a disaster. We did a lot of this during COVID, but resource requesting has to be funneled either if we as a hospital system need to make a request for a resource, like a staffing resource or equipment of some sort. We need to make that request either through the city or through King County. And then that gets forwarded up to the state, who would source it at the state level or the federal level if they don't have it at the local level. And then our emergency management partners are responsible for creating situational awareness for for our elected officials, as well as for all of us, for us to know, oh, hey, the EMS system is only working at half capacity. And that's huge for us as healthcare to understand that, or vice versa. If we are full, EMS needs to know they're going to wait a lot longer to drop off a patient, and turnarounds will take longer. The other place where this became really, really relevant during COVID, and I shared this at the Seattle DMC meeting, was during COVID, there was a meeting held, and I had raised my hand and said, can I please be the healthcare representative at your meetings, because I want to understand what's going on globally as well, so that we had a lot of testing sites and vaccination sites, and we wanted to understand what the needs were in the city. And so at one of the meetings, kind of as they were discussing school going back in person, one of the suggestions was to have all students and staff be tested before they come back. And I was able to quickly raise my hand and say, well, hold on. We don't have enough supplies or appointments available to support this request. And it's just a great opportunity for collaboration and to have a conversation for us to say, we own all the testing sites, the primary ones in the community. We can't support what you're asking people to do. So it might be hard for them to come back to school if they can't get an appointment for a test. And so they came up with a different strategy. So it provides an opportunity for further collaboration and also gives us all that situational awareness, which we all need during a disaster. And then consideration for policy decisions as well. If there are certain policies made, like you shall get tested before you come back to work, there's an opportunity for that conversation to happen around with people like us who provide the testing. So, you know, like I mentioned before, I work very closely with all of our partners in healthcare across multiple counties, to be honest. We meet regularly, at least once a month, usually more often. And it's the bigger healthcare systems. At my own internal meetings, we have, Fred Hutch has a hospital within one of our hospitals. They're very close partners of ours for disaster planning, and Seattle Children's. Their providers are through UW Physicians. So we partner very closely with all of those teams, Swedish, Kaiser, Multicare, Franciscan, Virginia Mason, and Evergreen Hospital in Kirkland are all big advisory group members for this state around what we do for disaster planning and how we prioritize what plans we're working on. So you'll see many of us at the table, and we've all been working together for a very long time. But advanced planning and coordination is really necessary. It's great for me to have phone numbers of people at the Seattle EOC. I can call directly and say, hey, this is going on and I couldn't get through to your duty officer, and just know people face to face and know who to ask. Same thing with public health. Same thing with my partners. I work really closely, as you can imagine, with our campus partners for the University of Washington. And I can call any one of them for something that we need, and vice versa. They call me for things all the time. So advanced planning and coordination and that networking is really key to the success of any response. Ensuring the availability of utilities, which is why we did the presentation at the DNC. I called them up and said, hey, I really feel like your partners need to understand the criticality of some of these things for healthcare. And they agreed, which was great. Collaboration with vendors. We do a lot of work with our vendors to call them and say, hey, when the big earthquake happens and we can't reach you by phone, how are you going to know how to resupply us? And we work on plans with them. We work on plans with them around phone systems, around cyber events, because if they get hacked, it impacts us. So we do a lot of planning for that. And then with community response organizations, as well as with community organizations, such as yourself. So happy to be here today. That's kind of the high level of all the things that we do. And I'm very happy to answer any questions that you might have.
Anybody got any questions?
So I'm a hub captain in West Seattle, and we're kind of in a rural, relatively speaking, area, because if we had the bridges down, it would be a little bit tough to get people to dialysis or to your emergency room at Harborview. And how do you envision, if we had a 2-week period of time, is there anything that you're aware of that we could, cooperate with? I know there's the Medical Reserve Corps that can be deployed, but where would they set up their tents or whatever they would bring? So I just feel like we're a little bit out in the Netherlands and need help.
Yeah. Great question. I would direct you to ask Public Health Seattle King County, who's responsible for Medical Reserve Corps and those community plans. I personally am not familiar with what
okay. I just wondered if it came up with, like a hub and spoke, You know, if there was a design that would, you know, be intentional.
Yeah. Nobody has approached us for the hub and spoke to kind of set up a clinic, makeshift clinic in West Seattle. I'm not familiar with which clinics are in West Seattle. I could look into that.
There's
No,
a couple urgent care, but there's not really. There's Highline. Go ahead,
Yeah,
Cindy. You got the details.
Yeah,
Yeah.
it's okay, Danica, you don't know this, but
Yeah.
the year prior to COVID, we were working with King County Public Health to set up kind of like, what's the triage system? And I forget what the buzzword is, but semi-field hospital. Oh, surge capacity, right? Should we be an island? And COVID just stopped that sucker dead in the tracks, and we have not been able to pick it up.
Okay.
So answer Dolores is everybody recognizes it. Nobody's had the bandwidth to bring it back up again.
Okay.
Although I would like it talked about.
Yeah.
Well,
We're getting there. We're
we're
getting there.
There's a
Bainbridge
question in chat.
Bainbridge Island has a great program similar. So if you haven't already talked to them, maybe you can leverage some things they've already built. Yeah. I see a question in the chat. Is city EMS different from OEM and SFD? Yes. EMS is the emergency medical services. They are through the Seattle Fire Department, which is SFD. There are also transportation organizations that are emergency medical service providers like AMR and some others, TriMed, that provide transfers from either one hospital to another, a hospital to a nursing home, or sometimes they assist with our Airlift Northwest. We have Airlift Northwest also at UW Medicine for one of our programs. And sometimes they assist with us if a hospital doesn't have a landing pad, they will land near the hospital and AMR will meet us and transport the patient. OEM stands for the Office of Emergency Management, and that is through the city of Seattle, through the mayor's office. Assume that healthcare workers may not be able to help at your hubs. Healthcare workers are not licensed to work in the field. So if they wanted to volunteer their time, or if we as an organization set up a field clinic, they could do that. But if you have healthcare workers in your community, they would be doing that on their own, at their own liability. It would not be as a resource from one of our hospitals.
Right. No, my
Danica, I
question
think
is actually,
Go ahead, Bev.
okay, I was gonna say, my question is, say I volunteer at my hub and I volunteer to do some of the medical things that we have been talking about doing in the future, some medical triage, things like that. Should I assume that I may be called to work rather than to be able to do what I volunteered at the hub? I mean, not just me, but other people. Will hospitals be calling in healthcare workers emergently to come to the hospital?
There's always the potential for that, I would say yes. If it's an earthquake or if they work in a unit that is under-resourced, we would be calling them to come to work.
Danica, as a follow-on, don't most people know if they're going to have an assigned role in a disaster? They already know that.
Most people do, and most departments know what their role is in a disaster. Like, for example, at Harborview and other campuses, but also especially at Harborview, we practice our MCI. We drill it, and they all know what department they're in and if they have a role in that particular response. What I would say is that we have not had a lot of earthquakes where people may or may not know that they will be called to say, we really need you at work because your coworker lives in Arlington and can't make it here, so I would say yes, if I had to say yes or no, yes, I would expect people, there's always the expectation that they would get called to work, but I think it is event dependent. Thank you, Anne. Mass casualty incident, yeah. Which means mass injuries. In the military, it means something different. Yeah, that's okay. I've learned that over the years. Other questions? It's a good
I have a
question.
question.
Danica, you said trauma is not what you expect after an earthquake. What do you expect?
A lot of broken bones.
Okay.
A lot of broken bones, and lacerations, TB shots, not tuberculosis. You know what I'm talking about.
Tetanus.
Tetanus. Thank you.
Tetanus.
Come up with the word. Tetanus shots. Things like that. Trauma.
Okay.
There's not necessarily a lot of trauma historically. Now, that's not to say there won't be any, but historically, it's been a lot of, bricks falling off of buildings or people caught underneath a wall or a table or things like that. I think that Susie, I see your note. What was the city's response to your presentation? I think they were appreciative. We were asked to come back and work on a city-specific steam outage plan, which I think would be fantastic. I haven't heard from them yet, but it's only been a month. So I felt very well supported by our city departments, and we are also working with the water department on a water response plan as well. All of the hospitals, not just UW Medicine. Cindy, I see your hand.
Yeah, it's a little follow-up to the one you just asked. So if we have people who have come to the hub and said, hey, I've got someone with broken bones or lacerations, and we have figured out how to get those people to the hospital, that's where we should send them. You're not worried about being over capacity dumped on.
I think we're always worried about that. I think there's also, but that doesn't mean you shouldn't bring them to us. You should bring them to us. We are worried also in an earthquake about nursing homes and large numbers of people that might have a need to come to a hospital. If, say, there was a gas leak, as a result of an earthquake, they might need some supportive care. We will be busy. I don't think that we will not be busy. I just don't think it will be specific.
So in other words, if we can get someone transported to a hospital and they need something more than your maybe local first aid trained person can handle, it's get them to the hospitals.
Yeah, I would always err on the side of getting the medical need if that's what they need.
Thank you.
Assessment. Yeah. It doesn't mean that it'll be fast. They'll be triaged just like they would any other day. And it
Or
might
that
be
we can get them there, right?
get them there. Yeah. Some of the clinics, I see the question about beyond first aid, can we carry people to a clinic or a hospital? So the difference between planning for hospitals and planning for clinics, not all of our clinics have generators, is the first thing. There are some clinics, and I can't speak to the clinics outside my system, but some of our clinics are equipped to take an influx of minor injuries. And they can do things like set a cast and give you stitches and things like that, or refer you to a hospital. Clinics are also not 24/7. Can't guarantee the staffing of a clinic. We also, when we do surge capacity planning, we might consider as a healthcare system to pull staffing from a clinic, close that site, and staff the hospital if that's where the greater need is. Those are decisions that are made real time. There are certain roads that are prioritized to every hospital in snow, and I would hope that that would be the same plan they would follow in other events. To Harborview, to Northwest, to Montlake, to Swedish. I don't know about the routes down to Highline. You mentioned Highline. I'm not familiar with their plans. There are roads prioritized for some of the other hospitals in this area as well. Yeah, the Snow Plow Routes are basically, and then SDOT has the bus routes. So they do reduce their bus service, and I would hope that that's the same plan they would follow, but we would need to ask them what their plans are.
Yeah, for the hub captains, if you look at the maps, the UASI maps, and then the next set of maps that you got, you can see gold line streets and green line streets. And that is the SDOT's plowing and debris clearing. So the gold ones go first, and you can see almost all of those lead to critical infrastructure like the hospitals. And then the green are other major arterials. You know, so if you have clinics out in West Seattle, for example, and we're going, okay, no bridge, how will we know if any of those clinics are open or planning to open when earthquake, all communications down?
You know, that's a great question. We have different ways that we would try to publish what's open and what's closed for UW Medicine. We certainly would use social media if we have it.
No,
If we,
yeah, no, this is the no internet. This is the
yeah,
no
some-
internet, no nothing.
I mean, some people have satellite internet, so there are some areas that could have it. I don't know what kind of resources like the fire stations have out there that they could receive a situation status report and publish for the community. I don't know what the plans are in each community, but we would publish in the media. We would publish, you could call us if you can get through on the phone. And we could give an update on the phone. We usually update our website, our social media, and our phone lines around what's open and what's closed would be the primary way we would do that. But if we needed to partner with community partners to do it in a written fashion, we would probably work with Public Health Seattle, King County, and the city to help us publish what was available.
I think for the hubs, it's knowing where your clinics are and then sending a runner there to find out if there's any capacity.
Well, our deal with OEM is that if they have situation awareness information that affects, you know, broader people, they send it to, it's like the PIO system. They send it to Como, Cairo to go out broadcast over public radio, but it would also come over ham radio to all the hubs. So it would be, if you're getting that information to OEM, then they can, especially at the clinic level, they can gather that up and blast that out by both of those routes.
Yeah, we have ham radios in every hospital as well, but we would not know how to get it to your hub groups.
OEM's going to want to know it anyway, because they're going to want to know what clinics are open, because it has the same clear the roads to the clinic needs and stuff like that. Yeah.
Yeah, and I'm presenting to the medical services team, the ham radio operators for healthcare in November. So I can ask them if a lot of them have connections to the team at Seattle. So
yeah, we do too. Yeah.
great. Okay. Yeah. So we do, Marina has, if you know Marina Zutel, she's got contacts in every hospital. And I think actually at one of ours, her son is one of the contacts at one of my hospitals. So we got lucky. Urgent care in more places. That's a complicated licensing question. If your clinic in your community is not already an urgent care clinic, it is not in the moment going to stand up to become one. There's certain types of services we have to be able to provide to be an urgent care clinic, and types of providers that we need to have. And so, it's unlikely that we would move urgent care providers into a community that is not normally urgent care. I'm not going to say it's outside the realm of possibilities. It depends on how long a disaster goes on for and the community need, I think, but it wouldn't happen quickly. We hear people talk a lot about, let's stand up a field hospital. Unless that field hospital comes with providers and nurses and protocols and medical oversight, it becomes really hard for us to stand those up in the community, because they then come ask your local healthcare teams to do it for them. Which doesn't mean that we can't, but it's not fast.
The other aspect of the planning is that we've asked for 20 years, why isn't there a plans to put a hospital out here? And you learn early that people say that the public health system does not plan hospitals. Those are privately owned. And if there is not a business case to open a hospital in a community, a hospital or an urgent care or anything won't work anymore. It is business plan driven.
It's actually driven by the Department of Health. There's in Washington State, I'm not sure about other communities, but in Washington State, you have to get what's called a certificate of need, and they only give them out. I'm not sure who at the Department of Health does the evaluation of what communities need a healthcare facility, but you have to go through a certificate of need process to even request to build a hospital. So the behavioral health hospital that we just opened this year, for example, we had to compete through a certificate of need process because they would only give one license, even though we have such a need for it in our community. And there were more hospitals than one willing to do it. There was only one certificate issued by the state, is my understanding of that process, but it's also very costly. And that was a partnership with the governor's office, and the cost was enormous for that, and the need was enormous. So it's a success in that mind, but it's not just about the business of the hospital making that decision. We have to get permission from the state.
One hospital you haven't mentioned is the VA Medical Center. That's could be in the play for capacity, and
It is. We do have some providers that work there as well. And I do partner with the VA. The ability to send patients there that decision has to be made at the federal level for them to accept community patients, civilian patients. And I think it has been done in the past. I can't recall exactly when, but it's not outside the scope of possibilities for sure. Let's see. Best course for people on dialysis. I would encourage them to talk to their center about their disaster plan. My understanding, and I could be wrong, is that most dialysis centers also are required to have generators and a water plan. And so I would encourage them to talk to them first about their plan, and if their center is down where they would expect their patient to go, they should have a continuity of plan, continuity plan for their patients, just like we do for example, if you have in your communities anybody with a VAD, a ventricular assistive device, those have to be charged. And so when they get discharged, we go through disaster planning with each patient and talk to them about making themselves known to their communities, know where their local fire station is that's closest to them, and that they know about them in the community and that they have this need. So if they are without power for a long period of time, they can power their heart device. I would assume that the dialysis patients could have that same conversation with their providers around what the plan would be for them. And the Kaiser location, they have an urgent care, but not an emergency department, and that might be the difference between the snow routes. But you would have to ask SDOT around how they make that, how they deem the snow routes. I don't know how they do that. All right. Well, thank you so much for your time, and I hope you can make it to your next thing that you were hoping to get to. So I really appreciate it.
Thank you very much, Danica.
You're very welcome. Reach out
Thank
anytime if you
you.
have further questions. Thanks.